Hello, everyone. I'm Peg Bolgioni, and you're tuned in to the Southern Vermont AHEC Let's Talk podcast. AHECs are national organizations focused on cultivating and supporting the health workforce, particularly in rural and underserved areas. Today, our discussion revolves around health equity and reducing health gaps by ensuring everyone has fair access to health care. Joining me are my two esteemed guests and Southern Vermont AHEC board members, Dr. Rudy Fedrizzi, District Director with the Vermont Department of Health's White River Junction office, and Elizabeth Austin, Executive Director of the Good Neighbor Health Clinics and Red Logan Dental, also based in White River Junction. So welcome to the podcast.
Happy to be here, Peg.
Thank you. Okay, so I think we'll just get started. Let's begin with, how did you both come into the field of health and eventually into public health? Elizabeth?
So, thank you for having us here today. I grew up in a town where the career options were really limited, and I was inspired to go into healthcare because I wanted to make a difference for others. I started as a kitchen aide in a nursing home in a really small town where there wasn't a lot of opportunity for growth. I left for college and have been in various roles while my husband was in the service, and I was consistently impressed with rural communities and their efforts to improve health access. It was really inspirational, and I could not wait to be a part of it.
All right, excellent. Rudy?
So I was drawn to medicine as a helping profession when I was in my teenage years. It wasn't like I was 5 years old and had the, medicine kit and wanted to be a doctor from my earliest days. And so I went to medical school in St. Louis and then did my residency in Nashville, Tennessee, and practiced OBGYN for about 17 years. But then I was a bit disillusioned by medicine. I felt like a lot of what I was doing was reactive and really rescuing people. And I was much more interested in health and wellness and prevention. And so I began a career in population and public health and have done that for the past 15 years or so. And I've said I started my career thinking of individuals or families as my patient, and now I think of the whole community as my patient.
Everything that we do in our lives impacts our health in some way, whether it's social, financial, environmental. Health is something that we should all put on equal footing. We're all going to get sick someday, and we're going to eventually die. Why should this have any relevance?
I've realized, as I just said, in clinical medicine, I thought that health was being free of disease. And if I could help people get over their illnesses, then I was doing something important for their well-being. I've learned instead that quality of life and a person's holistic view of well-being is much bigger than just their health conditions or their illnesses. And so this idea that health is really about thriving in every way you can imagine. And we've heard people describe this as where we live, learn, work, play, worship, all those aspects of our life. So I think that's why health is relevant. It's much bigger than just putting off serious illness or prolonging people's lives. It's something more about the quality of a person's life.
Elizabeth?
Yeah, I think it's easy for all of us to recognize that death is a factor of life. And however, science, history, and data have proven that many people still suffer severe illnesses sooner than other people groups. I'm consistently amazed that for many people, their zip code actually still determines their life expectancy. And that's been something that's been interesting to me working in public health throughout the United States. The relevance of health equity really begins with how seriously we take it in our communities. And health equity can be an uncomfortable model for business when we think about it, but there's so much that we're not familiar with when it comes to developing interventions or programs. But it's up to us as those in the community and health leaders to ensure that there's success with necessary fundamental change in how we look at health. And it's something that begins at home and begins in our communities by elevating and listening to voices in the community and their experiences.
I think people tend to throw around health equity like a buzzword and without really knowing exactly the true meaning. And that's why I think it's great that we're having this discussion to kind of delve into this deeper. Let's define health inequity.
When we think about health inequity, from what I see, in a rural area, it's really hard to motivate people who do not have access to healthcare to begin with to get care or seek care out. Often, what I would define as health inequity are the people who have been turned away or don't have trust for traditional health systems because there is systemic racism or historical issues with the way that they've had access to care. Poverty, levels of education. We work with a population of people that have a hard time reading, writing, and when we can give them time to get them care, how are other organizations giving them time to get them the care that they need? And are people who are coming here who speak different languages, with English not being their first language, do they have the ability to fill out forms to get care? Are those things readily available in their language? When I think about health inequity, it's the way that health is accessed, because many people who maybe don't have English as a first language are already experiencing a hardship by having to seek out a form or a translation service to get what they need. And I think we need to think a little bit more globally about how we increase access to care to make it equitable.
I think that was excellent, Elizabeth. And the only thing I would add to that is that some differences in health, so some disparities in health, are not unfair. They are just the nature of health. So example might be that women tend to have a lower hematocrit, a blood count, than men. And that's just the way it is. And that difference isn't necessarily a health inequity. Inequity is when differences become apparent because of unfairness, unjust conditions, issues, as Elizabeth mentioned, about racism and access, stigma, things of that nature. So there are differences that are natural, and there are differences that are a reflection of gross inequality and inequities in our system.
Okay, that's perfect. Thank you. I know you both can provide very unique perspectives on health equity through your own experiences, which you briefly touched on. So to both of you, what are your partnerships and priorities for health equity, and how do you know you're making any improvements?
Peg, you're right about health equity being a difficult concept. Let's just set the stage on how some of us see health equity. I like to think of it, and I've seen other people describe it as giving everyone a fair and just opportunity to have the best health they can have and try to eliminate those barriers that are unfair. And obviously that's really important to everyone. In terms of other things about health equity that I think are important is we often don't humanize health. We talk about percentages. This many percent have this. We're very quantitative in terms of the data that we use. And I think health equity invites us to be more qualitative in how we describe our health. I think storytelling becomes really important in terms of health. And so that we hear a person's story and we have empathy for that, or we can see ourselves in some of those stories about folks that are struggling with their health or struggling with barriers to health. So those kinds of things are important. The other thing about when I think about partnerships and priorities in health is, as Elizabeth just mentioned, I don't think enough to get the voice of people who are especially burdened by barriers to good health access, and we have to do better, especially in the public health arena. We try to invent solutions and imagine what might work, and we forget we probably should ask those folks that are experiencing these problems, and they'll probably have really good ideas of what they think would work and what they feel like they need. And the other thing I would say about partnerships and priorities is I go looking for very atypical partnerships. I'm very willing to imagine that even folks that you'd think may not be wholly on board with a particular health topic that's important to me, I'll bet there still is some desire for them to see that health issue addressed effectively. And I have a couple examples in my own career. One example is when we would do projects around trying to limit youth exposure to alcohol, for instance. We actually did projects where we would involve alcohol distributors and ask them to help us sticker, we called it sticker shock, sticker their products with stickers that would say, hey, it's illegal to buy or provide alcohol to underage youth. And they would be completely open to the idea of allowing us to sticker their alcohol products and cases with that kind of message, because I think deep down they did not want a child to be harmed, drive a car impaired and have an automobile accident. And so who would think that, the alcohol distributor would be the one who could participate in alcohol prevention project. And the other is we did some work in the past around gun violence prevention, especially in youth, and found that some of the gun rights organizations actually were willing to provide free gun locks so that guns could be properly stored in the home and not available for youth to somehow find a gun, especially a loaded gun, and be able to harm themselves or someone else with it. So the idea of atypical partnerships and not assuming up front that people who you may not think have the same desire to see the same outcomes that you do, I think that might be short-sighted. And I've had experiences where I've actually gotten good synergy with folks that would otherwise be seen maybe as in opposition to some of the public health goals that we had.
Elizabeth, did you want to comment?
Absolutely. When I think about our partnerships and priorities for health equity, it really starts with the organizational commitment of caring, right? Caring about health equity, but also those in need of their services and their experiences. When we think about providing care, we also need to be caring about those that are making that care possible, the workforce and their experiences in workforce, but also the diversity that's represented by our workforce and how we can better care for patients in that way. When we think about the priorities for health equity, I believe that all of us have the responsibility to examine what we think we know about health access, but also how equity is delivered in care. Those that we partner with to deliver healthcare services, also we need to be looking at how they're responding to health equity and how they're making those things possible. We can recognize that we're making improvements when there are larger scale things like policies that are shifted, or even smaller things like what Rudy referred to with the stickering on the alcohol. There's so many challenges that these patients are navigating when it comes to specific social determinants of health. And even if we can find one way to make something better for them, that's huge, because these patients are experts in their experiences and we have a responsibility to listen to them.
Yeah, I know you're actually living in this space, Elizabeth, right, because of the work you do, the boots on the ground initiatives. And this is a perfect segue into the health workforce. And I'd like to talk a little bit about that. Our goal at Southern Vermont AHEC is to help train and develop a highly qualified and diverse health workforce, especially in underserved and rural populations of Vermont. How do we encourage those who might not think about health careers as an option to pursue this pathway, especially those individuals who might not think it's within their realm to do so? So I'm putting it out there for you guys. Let's hear what you have to say.
Well, I've learned that since transitioning from clinical medicine to public health, just how nearly everything impacts health. We talk about the social drivers of health. And so my view of the future workforce in the health arena involves positions like community health workers, people who are peers of community members who are going into the homes of people and have similar life experience and can help people understand those difficulties they're experiencing because they themselves may have experienced some of those. I think of positions like, laboratory workers, people who are in the social service arenas of food access and transportation. All of those things are so impactful for health that I think if we, rather than narrowly say, oh, you want a health career? Well, that's a doctor, a nurse, that sort of thing. No, it's not. It's many, many, many opportunities out there to have an impact on people's well-being. And so I think the idea of broadening the definition of the healthcare workforce is important. And then the other thing is that you can have impact at the individual level like a home care worker or a visiting nurse or some positions like that. But you can also have impact all the way up at the policy level if you're a legislator who has a particular interest in health and well-being. So I think one thing we could do is, broaden the definition of what it means to be the healthcare workforce. And then the other thing I would say is I know that the healthcare workforce crisis is very difficult, but I also know that both myself and Elizabeth benefit from the volunteer workforce, and that both of us are lucky enough to attract folks, often retirees, who have time, whether they're Medical Reserve Corps volunteers, which is a federal program of being prepared for the next serious disaster or emergency in a community by having this ready-made, ready-trained group of volunteers who often have some medical training, but don't necessarily have to have medical training. And so I wish that we would give more attention to attracting people who are perhaps retired, perhaps lonely, socially isolated, and invite them to volunteer with us and perhaps be part of the solution to our current workforce challenges.
Okay, Elizabeth?
Yeah, there's a perception sometimes that a career in health is not possible if you don't have experience working in it or if you haven't had the exposure. And I think about what Rudy said about the volunteer opportunities, and I think that it's really important for youth to have the opportunity to have volunteer time and to be able to have exposure to healthcare careers, because healthcare is not going away. It's something that we're always going to need, and there's a lot of room for growth. And I think particularly in rural areas, it's hard for us to fill these positions because there's other factors like housing or cost of education. But when we think about what people's backgrounds are, it's impossible to not join healthcare and not make some semblance of a universal difference. Every position is needed, and every position relies on the other position that it's working with to make the healthcare system happen. And I think that it's important that we hold space to value each of those roles in the health system, because, like Rudy said, it's not just the doctors. You have lab workers, you have folks that run the front desk. And we certainly saw during the pandemic, when those roles were vacant, how difficult and how much they impacted our work and the delay times and the quality of patient care. So I really appreciate what the Southern Vermont AHEC does with getting, young rural areas involved in healthcare and making it possible for people to see the opportunities that they can have.
What would you both recommend? Because this is a social issue as much as it is a medical issue, or a health issue. And for students that are thinking about pursuing a health career in some form or fashion, what would you suggest in terms of preparation? What should they be learning in school besides the sciences? Do you have anything to say about that, or any comments?
Well, I think the more well-rounded you are, and the more that you have some of the soft skills that really allow us to build trust with the community, with making connection to the clients that you may serve in the future, is really important. So I tend to be someone who feels like the technical aspects of whatever career you choose can be taught, but those soft skills, that you're a good communicator, that you're confident in front of people, that you can have compassion and empathy and understand that people's struggles parallel your own struggles if you're honest with your own life journey, things like that. To me, that's really important. And so the kind of student who is not so focused on one career path, but sort of gets broad education, including, the humanities and things like that, I think makes for a better healthcare worker in the future.
Okay. Elizabeth?
Absolutely. When we talk about social determinants of health too, I think if we talked about those things more in school, students might realize that maybe they fall into different categories, or the district that they are living in might fall into a more rural category. And so they might be able to see, well, how can we be creative with the opportunities that we have in front of us, because we fall into a category where we might be more disadvantaged than a different group. And what can we do collectively to make a difference here, either in our community or for ourselves as individuals? That that thought process would really open a lot of doors for students because they wouldn't feel held back by the monetary value of going to school or being worried about paying for school, because people are really starting to see the value in funding education, but also how education is taught. And when we think about how health education is taught in America, there's a lot of ways that we could improve how students view themselves before they're even out in the world. To emphasize what Rudy said about having compassion, it might help students be able to see that there are other people like them out there, and that if they want to help them, that's an opportunity, and that they can help themselves by learning first.
Okay, very well said. Thank you.
And one of the, let me just say, Peg,
yeah.
Elizabeth makes me think that one of the assets maybe we have in our rural communities is that we're small, and if we do choose to work in our small communities, we're really helping our neighbors. And that there's something very special about that idea that you're just not a worker in a large machine of a factory kind of setting where you don't know the impact you're having every day with the kind of work you're doing. But in these small communities, you know your neighbors. You may see people come through the door of your clinic or a hospital or social agency, and these are people you may know. And there's something, I think, very special about feeling like you're having an impact locally and with your own community that I think is powerful.
All right, excellent. We're almost getting down to the end of the podcast. I didn't know if either of you had any final thoughts before we closed out.
Absolutely. I think we've made great progress in our communities over the last few years. And I think the pandemic really brought to the front of all of our minds the different ways that we can be helping at home, the different ways that we can be helping in our schools, in our communities, and really who was left out during the pandemic. Are there folks that really were struggling to get access more? And when we think about health access and health equity, how are we reaching the communities that need our help the most? And are we thinking through their lens and their experience? And often a lot of us come together and work in huge groups, but are we bringing those voices to those groups that need to be heard? And I think there's great value there. And I've seen a lot of people start to shift their thinking that way. And it's been an incredible movement.
Okay.
And Peg, I think you mentioned a bit earlier about partners and partnerships. And one thing I have to say is I can name a lot of partners in my work life. I don't know that I can name as many deep and impactful partnerships. And so I think the future of public health and the impact we can have on health is going to involve some of these models of intentional connection and interaction between organizations and individual providers. And so there's a approach called collective impact, where you meaningfully try to bring together organizations in ways that work in mutually reinforcing ways to have impact. And I think that may be something that we can explore more in the future than we have in the past.
Okay, and I know we're not finished with this topic yet. And in future podcasts, we hope to dig deeper into the impact of health equity from social determinants of health to improving education access and examining how health disparities affect disadvantaged populations. This podcast and others are available on Spotify, Apple, Google, and Audible. And just search for Southern Vermont Area Health Education Center on the apps or websites, and you'll find us. And thank you both for being my guests today, and to our audience out there, thank you for listening.